I have three colleagues presenting today, and all three of them are well known to some of you and not to all of you. So we have Alex Lee, who's been with us since 2001. His undergraduate training was in Edinburgh, and then he did quite a bit of surgical training locally in the UK. He's done his PhD in the UK as well, and played very important management roles for the British Association of Paediatric Surgeons. So Alex's topic will be Oxford Tube Service. I'll just introduce the next two speakers as well. And the way we'll run it is after Alex's talk, we'll have time for a few questions, and then we'll move on to the next, because all the topics are different. My next colleague is Mr. Junaid Ashraf. Junaid did his undergraduate training in Pakistan, but came here as a qualified surgeon and did a lot of the pediatric surgical training in the UK, including a fellowship with the UK board as well as the European board in urology. He's a new colleague to Oxford, but a known colleague in the UK, where he moved from Leeds, having worked there for almost about 10 years. So very welcome to have a very senior colleague join us in urology. And our third colleague is Eva Coates. Eve is a medical student from Oxford and Cambridge, so many of you would know her. She did all her training in the UK and also did a fellowship in colorectal surgery, which is her interest. And currently, with a lot of talk in our department regarding AI, Eve has been very smart, and she's doing a diploma in the Syed Business School on clinical data informatics. So we are very lucky that once she has that, pediatric surgery will be there with the AIs. So without wasting any time, Alex.
Good morning, everyone, and thanks to Kokila for the introduction. Just in case you wonder, I'm not selling you tickets to go to London, but I used to work at Oxford Tube Service because a lot of things we do involve a tube of some sort. And indeed, what I'm talking about is about feeding in children who need a surgical intervention. Most of these patients require a gastrostomy for feeding, and we can do this by various means. You usually end up with them having a gastrostomy button long term, as shown in this photograph. But some patients who cannot tolerate gastric feeding require jejunal feeding, and could be a gastrojejunal tube like this patient, or some patients will need a surgical jejunostomy where it is separately fed from the stomach. However, some patients may not even be able to tolerate a gastrostomy at all because the stomach may not be in the abdomen. And for these patients, the only way to get into the gut will be through the jejunum directly. In Oxford, we insert about 60 to 70 new gastrostomy a year, and about 700 patients in the region have a gastrostomy for one reason or the other. A smaller cohort of patients, maybe just less than 10%, have very complex needs where the stomach feeding does not work, and therefore they need jejunal feeding. And these patients do have much a higher logistic burden in terms of the needs for changing these tubes in the hospital rather than in the community. About 8 years ago, I led a group under HSN Patient Safety Collaborative looking at the safety aspects of gastrostomy care and enteral feeding care, and which involved clinicians of basically all specialties which are involved in the management of these patients, as well as nurses, dietitians, patient safety researchers, and more importantly, parents' representatives. And through this work, we try to standardize a few things, especially in terms of post-operative care when they go home. And we also did an analysis using the national safety reporting system, learning system, where we noted that there were many incidences about problems when patients have a feeding tube at home. And one of the sort of conclusion is that the parents do need better training and also about their expectations. On top of that, of course, we do have problems with bad access, theater access, and the jejunal tubes do have a higher logistic problems and issues, challenges that I mentioned earlier. So as a surgeon, there are three aspects that I consider when I'm asked to do a gastrostomy or a true feeding of some sort. First of all is, where do I want the tube to end? Is it in the stomach, in the jejunum, or in both places? Secondly, I would think about, how do I get it in? And thirdly, I would think about, how do I fix the stomach to the abdominal wall? And I will mention this later on, with the gastropexy. So previously, and still a lot of surgeons will do a PEG, as shown in the upper photograph here, where it's endoscopically, and in some centers, gastroenterologist does this. But most of these patients eventually will then change to a button gastrostomy, usually through an endoscopic procedure in theater under general anesthesia. However, more and more parents now request to have a primary gastrostomy button because it's the only one device to learn. They only need one theater trip and one general anesthetic. Because remember, a lot of these patients do have very high risk for general anesthetic, and as a result of that, they often do need to have critical care afterwards. So we did several QIPs to try to improve the perioperative pathways, and in the last 5 years or so, I have done over 250 laparoscopic gastrostomy with gastropexy, and by this we managed to basically save a second procedure of the change in these patients, except for 2 patients who did return to theater for some minor wound issues. And all these patients now with a standardized pathway, they usually stay in the hospital for 2 days and some of them 1 day, unless there are other comorbidities. And time in theater has also improved over the last few years, and more or less for the straightforward cases, we can usually do it within an hour. Now, regarding the gastropexy, this is a very important concept because previous with a PEG tube that we put in, the natural adhesions will form a gastropexy between the stomach and the anterior abdominal wall. But if you put a balloon device in, the balloon might fail any time, could be the next day. And if that's the case, the stomach will come off. And therefore, somehow stitching or attaching the stomach to the abdominal wall is very important. And previously, I used these gastropexy T-fasteners or T-bars, which is used in radiology for a while previously. But what I find is that they do have problems, and I only used it for a few years. In the last few years, I've changed my practice following a QI that we did, where we found that the time that is required to do the subcutaneous sutures is not as much longer. So now this is my default way of doing it, basically putting 4 subcutaneous sutures where I can stitch the stomach laparoscopically. Now, that's all gastrostomies, but for a small cohort of patients with focal dysmotility or one reason or the other that we can't feed gastrically, they need jejunal feeding. In general, I would advise try to avoid them because they do have a lot of issues with jejunal feeding, not just the logistical issues, but also they have a risk of interception, perforation, and various other issues. However, some patients do really benefit from having a jejunal feeding. This can be done either as an existing gastrostomy or as a completely new de novo procedure. And there's, and as I mentioned earlier, these tubes need to be replaced in hospital, and previously we do it in theater, and I'll tell you what we've done more recently. A lot of these patients in the past have fundoplications, and fundoplications used to be one of the commonest general operations that we do electively. However, there's a really significant decline in the last 10 years. And this paper a few years from New Haven in Yale show that even the Americans who used to do a lot of fundoplication, they have also reduced significantly in the amount of fundos that they're doing in the recent years. And a lot of patients traditionally have a fractured GJ tube, a gastrojejunal tube, which shows here, which I think some of my adult colleagues will be very familiar with. This is often done in adult radiology and by the gastrologist, where there's a tube inside which goes to the jejunum. However, these tubes can have a lot of other issues as well, and in children, to change the tubes often require general anesthetic. And this one particular patient had Barrett bumper syndrome in the extreme that the bumper, that the flange actually migrate up all the way to the skin, which we eventually changed it back to a low profile, a GJ tube, and now this child is almost a man now, so it's now grown almost an adult, where because the abdominal wall is so thickened now that we need to have a tube which has adjustable length, as shown in here. For patients who need a GJ tube up front, I've done about 17 patients in the last few years. Most of them are babies who often is ICU where they can't basically progress because they're aspirating with reflux. And we do this operation laparoscopically, just like I did the gastrostomy, but at the end, with endoscopy and fluoroscopy, we guide the tube into the small bowel. And a lot of these patients do actually graduate back to gastrostomy feeding, which is lovely because it's as mentioned earlier, the logistic burden much less if it's in gastric feeding. But some patients can't even cope with gastrojejunal tube feedings because of various reasons. For example, if the tubes keep coming out, or one particular patient with the X-ray that I showed earlier, where if we can't get the tube across the duodenum in severe kyphoscoliosis, then a surgical jejunostomy is required. And I normally do a Roux-en-Y jejunostomy. I appreciate that some centers, especially in adults, will do other types of jejunostomy, but in general, I would much prefer a Roux-en-Y as shown in this diagram. And whereas before I put a normal gastroscopy button in, nowadays I put a transjejunal tube, which have a trimmable extension that you can cut it the length so that the milk is further away from the skin. However, like most jejunostomy, they do come with complications as well, and can be major complications, especially when the bowel itself is abnormal, which is a big number of these patients that we've got. So because we have to change these tubes previously in theater endoscopically, it is really quite difficult because these patients have high morbidity, as I mentioned. So with the number of QIs, and ultimately, we established a service a few years back where we worked together with the radiologists who were previously a bit reluctant to do this, but now they're very much embraced in doing this work with us. And you can see in this chart that the number of cases we've done has significantly increased in the last few years since we started doing this. We're now doing about 100 cases a year. And in the last few years, we do more than 400 cases, and all these patients came without, were done without GA. They were done unwake, and you can see in this photograph that the parent is actually part of the team as we're doing it for these procedures. So far, we have one patient we couldn't get a tube across, and this patient then have a surgical jejunostomy subsequently. Most of these patients come as a day case because they don't need theater, they don't need GA, so they don't need to be admitted afterwards. And most of them stay in hospital within less than 2 hours. Now they don't even need to buy a ticket, car park ticket, more than 2 hours because they know that they can usually come in and out very, very quickly. Additional benefit is that they have less radiation compared to when we do fluoroscopy using C-arm in theater. And as mentioned earlier, we have now increasing referrals from the PICU and respiratory teams. These patients are done electively. We have a list 2 afternoons a month or expedited to be done in these lists. And sometimes we have patients done as emergency. And for GJ tubes, we change it every 6 months as a default. And TJ tubes, the transitional tubes, we change it every 12 months. In 2024, last year, there are 48 patients use this jejunal tube service. We've done over 100 cases. As you can see, that's with planned, expedited, and emergency, as shown in these graphs. And in January, we did a patient experience survey, online and online survey of these parents. We sent out questionnaires for them and asking them relational questions using a tool, a validated tool, care tool. And then we also asked them functional questions about some practical issues about our service. And as I say, the planned expedited are done on our list, and then there are some patients that are done as emergencies. And of the 48 patients, 6 actually died by the end of the year. And we have a good response rate, overall response of this survey, over 60% within 2 weeks. And we only asked relational questions to those who died because the functional question is not relevant to them anymore, and they have a good response rate. So what did they say? As far as the experience is concerned, basically they all score very good or excellent. So they really like the way that we have been handling them because these patients often have very complex needs and do really need a lot of care, if you like, in looking after them. But for the functional questions, we don't do as well, especially in terms of the confidence in dealing with the tubes, so when they're blocked and displaced, especially in emergency situations. And also the support, especially from community teams. They feel that they often do feel a bit lost when in the community, and they feel that they need further training. Now, we have done And also, not surprisingly, they are more satisfied when it is done as an elective procedure than emergencies. We also ask them for free text responses, and in general, they feel that we are friendly and very helpful to them and respect their needs. But they appreciate that we are a very small team, only myself as the main surgeon, a radiologist, and one CNS only, and therefore they'll be concerned that if one of us ill or if the machine is broken, then what will happen? We previously have done some work with gastrostomy. Now, that was jejunostomy I'll talk about just now, but gastrostomies in terms of helping parents in their training. And we survey over 150 families around the country, and we develop some videos which are co-produced with the parents. So they are actually in the videos themselves, which has been extremely useful. And I use these videos before the patients come to my clinic, and certainly before the operation, so that they can doesn't need too long of a training whilst in hospital. And these videos are hosted in an Oxstar, which is linked to YouTube, freely available, and everyone can watch them, and which is particularly useful for relatives or friends who might be looking after the child at home when the parents are not there. We also develop some simulation models when the patients are in, the parents can play with these models so that they know how to deal with the devices to help them to be more confident in dealing with the gastrostomy. And we're going to do some work on videos for GJ tubes, especially with the experience measurement, the PREM that we did recently. So we've been transformation in three aspects. We have changed the way that we do gastrostomy as a primary procedure. We mostly doing lab buttons now as a single operation. The GJ tube, the jejunal tube surface, has changed from going to theater under general anesthesia to now we change it in radiology without anesthetic. And also we prepare and empower and support the patients and also the staff by using the videos and the models I mentioned. And it was particularly useful during COVID because people did not want to come to the hospital. And I was very pleased that we started the process just before COVID. There are a lot of challenges. We need the expert role from various people, including parents, for them to buy in. But more importantly is the role of the specialist nurse, which is fundamental in what we do, because it's a very important link for us between us and the parents. We have also done a number of sharing and training events around the region, as shown here, where the parents also involved. In fact, in top right is a parent showing us how to do a blended diet, because most of clinicians actually doesn't know how they actually do it, because they have the most hands-on experience in doing these things. But one big challenge is about transitioning care to adult surfaces. So on the left, you can see that the prevalence of life-limiting conditions in children has increased by 250% in the last 10 years. And a lot of these patients now survive longer, and therefore their deaths per year has also reduced, which means that all these complex patients will increasingly become going to the adult surfaces in the near future. And in one of the talks we did, we invited one of the adolescent urologists in Reading, who also talk about their needs as well as the challenges when these patients transit up to adults. So thank you for listening to my talk. I hope it gives you some insight of what we have done. This is Sam, who is in one of the videos for the GJ tube. So he's actually got a jejunal tube. He's a child who has esophageal atresia, who is now fed partly through jejunum. It shows that even the child himself can actually do a lot of work and doesn't necessarily need any help from health professionals. Thank you.
Thank you. Lovely. So I'm going to be thinking about the colorectal cohorts that we have and two conditions in particular, aneurysmal malformations and Hirschsprung's disease. We've identified that female infants in particular grow up to be female adolescents who may have gynecological complications arising from the surgeries that we've done or related to the conditions that they have. And transition is all about joint working, and in this phase where we don't really have the frameworks and we're building them as we go along, this is how to put together a transition service with these considerations in mind. So we've got a cohort of patients. I've looked at the last 5 years to try and identify the patients who are going to need mindful transition. The patients I'm discussing today actually presented with their problems. I can't take credit for finding their problems. So they presented with their problems, and you'll see why this matters. So we've got 17 patients with erectile malformations who are within the 5 years upcoming to transition. 8 of them are female, and then we've got 12 patients who are coming up to transition with Hirschsprung's disease, 4 of who are female. And within that cohort, we've identified gynecological anomalies. The first case, 13-year-old, her story is when she was a baby, she had a cloaca. Now, for those of you who love embryology as much as I do, this is a condition in which your proctoderm, which is a specialized bit of ectoderm, is meant to grow into your body and meet your endoderm, which is your GI tract. And these two things are meant to meet at the same place. And if that is successful, then you have a bottom and you can open your bowels. Your urogenital septum is also meant to descend, and it's dividing your female and urogenital tracts from your bowel. So what could possibly go wrong? So in a case of females, what does go wrong is when the ectoderm grows in and forms the point where the bottom should open into, the endoderm misses it completely, and it can open in 3 points. The most common anomaly we see is where it opens into the vestibule of the vagina. However, it can also open between the vagina and the anus, so in the perineal body, and we call that perineal fistula. Or more rarely, but quite significantly, it can open into the urogenital tract. So then you have a common opening of your bladder, your vaginal introitus, and your rectum, and this is what we call cloaca. So this baby was born with cloaca. It was recognized. It was repaired. However, the first repair was unsuccessful. She had stenosis, and so there was a series of redo surgeries between the ages of 3 and 4. She was then lost to follow-up. In defense of the service, this was due to familial chaos rather than a concerted effort to lose her to follow-up. We find that actually she's 100% right. It's all blocked. The perineum has scarred. And when we take her to theatre eventually, we find that there's complete occlusion. So the first image was an ultrasound, which was then followed by an MRI. And what you can see here, this is the vagina, and you can see it's long. This is the upper part of the vagina, and a lovely view of the cervix there. And the distal vagina is strictured down, so it's not opening out to the world. Above the cervix, the uterus is also blocked. So at that point, we have a discussion between ourselves and the urologist and the gynecologist, and we think, well, we'll probably need a lot of vaginal tissue for a reconstruction. So why don't we leave this a while? Why don't we wait for menarche, and then hopefully we're going to have an autodilatation as her periods feel things, then we'll have a little bit more tissue for the planned reconstruction. Now, NHS waiting times being what they are, the next time this system is surveyed is a year later. We can see we now have a problem. We may have over-egged it. So this huge viscus is the vagina. So massive hematometra corpus. So we then go to theatre, we do the EUA, we have a gynecologist, Mr. Hirsch, present with us, and we treat this with vaginoplasty ×2. And eventually with dilatation and vaginoplasty, we have an open vaginal introitus, and the follow-up scans are more reassuring. So before, we can see the dimensions were 16 by 12, and afterwards we can see the dimensions are coming down to a more reasonable number. So that's the first case. So what does this case make us think about for transition? Well, if you've had pelvic surgery or perineal surgery as an infant, you will have complications later on, and we must look for them. The complications in literature are similar to what we're finding. So we have recurrent fistulas, which we see early. We have vaginal strictures, which we see late when they approach menarche and the periods start, and then perineal scarring and problems with the perineal body. The perineal body problems are particularly significant because we have to think about obstetric outcomes. And this is where it gets expensive. So if we haven't thought about what could happen when this infant who had perineal repair then becomes an adolescent, there's enough evidence out there to suggest that this will introduce an organizational risk and organizational costs. So in series that have been looked at over many years, they find that ectopic pregnancies happen, spontaneous miscarriages are higher than we would expect in unrepaired cohorts. We also find that conception can be difficult. Some of these infants will grow up to be women who will need assisted reproduction. And then we also have problems with premature delivery, which is interesting because you wouldn't quite expect that or really understand why that would happen. But not medically indicated premature deliveries, it may be something to do with the size of organs, who knows. So there will be obstetric complications. So let's move on to case B. The second case is about, we meet her at 11 and we work with her till she's 14, but basically she had a vactral, which is a complex of problems that we find either because you've got esophageal atresia at birth or you've got an anorectal malformation. So that brings us to your attention. We then look at your heart. We may find that you have a VSD, as this girl has. You may have vertebral anomalies. You may have limb anomalies, and you may have renal anomalies. That's your vactral complex. So as part of our ongoing review in clinic, we recognize that there's really severe constipation. So you can see her x-ray from when she's 12 and she's full as a full thing. So we start laxatives, transanal irrigation, and we're getting good results. We increase the frequency of the stools leaving her body. However, when we see her in clinic, there's still a persistent pelvic mass. So what's going on here? We then request an ultrasound, which demonstrates that, yes, there's totally a cyst. Okay, so in this video, what you're looking at is there's a cyst in the pelvis, and next to it, there's something that's squished. So one vagina, two vagina, and you can see the vagina on the right of your screen is flat and empty, and then we're starting to get better views of another vagina on the left of your screen, and you can see that is filled with fluid. It is dome-shaped. There is debris sedimenting at the bottom of it. Yeah. So I think our radiologists are a marvel, and they have amazing instruments, but they're basically able to diagnose a hemivagina on ultrasound. So having done that, we chase that with an MRI, and we can see on the MRI this duplicated structure. So that's one uterus, two uterus. At the bottom of the uteri, there's the hemivagina on the left, on the right side of her body, left side of the screen, which is very full, and there's some sediment in there, and then there's another hemivagina which is empty and squished, and the bladder has been pushed out of the way, and a similar view here. So what we're treating as stools with manual evacuations and trips to theatre isn't actually stools, it's an obstructed vaginal system. So she goes to theatre, but before we do, this is a syndrome. Any clever medical students put it together? No. So this is a syndrome. The gynecologist in the room will tell us that this is ovira, obstructed hemivagina, and ipsilateral renal agenesis. And this is treated by division of the vaginal septum, and she does really, really well. So what does this tell us about transition? This tells us that transition is an opportunity to look for associated anomalies. And with this cohort, we need to look for associated gynecological anomalies. We already know about Meyer-Rokitansky-Kuster-Hauser syndrome, which is associated with the vactral. We know that with renal anomalies, we tend to see more gynecological anomalies. And in a very large cohort from Amsterdam, they've put together 128 patients from all over Holland over many years, and they found that a full 1 in 4 of all the females in the cohort had an associated vaginal anomaly. And you can see some of this is small beer, but some of these diagnoses are actually quite significant and may then affect future gynecological and obstetric outcomes. An even larger series from the Americans, where they've put together a national cohort of colorectal patients, also found similar numbers. So a full 1 in 5 of patients who are female, who have infant surgery, you need to look for a gynecological anomaly. So the Americans are suggesting that we stop calling it Vactral and we start to call it Vactral G. Yes, it's never going to take off. Vactral G, but that's to help us think about the gynecological anomalies. I'm all for this because I think, again, it is risky not to look for these problems, and it will introduce organizational cost and risk for the patients, more importantly. Which brings us to KC. So KC is a patient with Hirschsprung's disease, and she has infant surgery. She had a Duhamel repair. She's got ongoing constipation and soiling and abdominal pain. As part of the workup, she gets an ultrasound, and the ultrasound demonstrates a large cyst in the adnexa. And all of this starts when she's 12, large cyst in the adnexa. So she has a series of images, and then she has a series of trips to theatre. And in the first one, they do laparoscopy. The ovarian cyst, thought to be ovarian cyst, is drained. In the second trip to theatre, okay, maybe it's a hydrosalpinx. It's aspirated, it's drained. Third trip to theatre, hemorrhagic ovarian cyst, drained. Fourth trip to theatre, ultrasound drainage of right adnexal cyst. So it just keeps coming back. What's going on here? So we now get to 2024 and we do an MRI, and actually she's bigger, things are easier to see, and we see this for what it really is. She has no identifiable ovarian tissue on the left side. However, on the right side, this is a hydrosalpinx. So why are we getting hydrosalpinx? So you look through the literature and you find that Hirschsprung's children seem to get hydrosalpinx. So there's a series from Brazil where they found 2 girls, and they both had bilateral hydrosalpinx. Now, what's interesting about this is neither of them had started menarche. They'd just entered puberty. So it's really, really rare, I'm told, to have a hydrosalpinx if you are just pubertal. So 2 rare conditions in the same patient. A bigger series from Spain where they found 29 patients over many years who all have bilateral hydrosalpinx. So in this series, they start to say, what's going on? What can we think about as explanation? So is it adhesions? However, none of their patients have bowel symptoms. So you'd think if you've got significant adhesions in your abdomen from baby surgery, then you should have significant obstruction. No. Is it shared innervation? Is it because the nerves that the adrenergic supply to your Hirschsprung's bowel would have been the same supply that goes posteriorly to the inferior hypogastric plexus that goes to your tubes? Perhaps. Is it about the operation? Well, perhaps, because in the first case series, they both had Duhamel and Leicester Martin dissections, which involves some sort of posterior peritoneal dissection. However, in the second series, they've got a lot of patients who've had transanal approaches and a Suave operation, which is a different dissection. So we can't really blame the operation. Should we start to think about Hirschsprung's of the salpinx? Could there be a problem here where the same nerves that are meant to go to your bowel and didn't migrate distally enough, thus giving you Hirschsprung's, could this be the reason why your tubes are ectatic and dilated and abnormal? So it's fascinating thought, but more importantly, who needs to know about this? And the answer is a gynecologist needs to know about this. So it's all about the transition. So to conclude, female colorectal infant cohorts are vulnerable to gynecological complications in adolescence. Transition is treacherous. We discover all sorts of things that we weren't thinking about, and we are sad to find, and now we have to manage. Transition is not triumphalist. The idea that we get to 16 and we pass off these beautifully dusted off patients and discharge them and say, well done on your successful surgery, goodbye, it's not happening. Transition is actually a tricky time where we find new problems, new diagnoses. Why it matters is because many families would like to put the surgery behind them. Many families don't want to talk about the fact that their child has had their vagina reconstructed, their anus reconstructed. So it's a difficult conversation that it may not be well received by families because they don't want their child to carry this into adulthood. Transition is not pass the parcel. It's not writing a dear doctor referral letter, have these problems, goodbye. And transition is not one-to-one. We don't get to have nice conversations with our adult colorectal colleagues about things that we enjoy. We have to find gynecologists, we have to find psychologists, we have to find what our patients need and transition them in this way. Transition is work of prediction. It's about thinking about what problems your cohort might have and using the literature to guide you. It's a one-to-many affair. We transit our patients to many teams. It's transition to the patient. We tell the patient, these are your problems. These are the things that will happen to you in the future if left unguarded. It's about risk management. There will be organizational costs that we have to think about if we ignore these problems. And we've talked about the psychological and cultural elements. This is a tool I've developed for our Hirschsprung's patients and I'm working on for our anorectal malformations. It's a summary page and it goes to a colleague and basically says, here are 16 years of what we've been doing, have at it. And if I had my way and transition was perfect, I think the things that we need to prioritize on as an organization is firstly, specialist MDT clinics that are actually in our job plans and are funded. We need joint operating lists. So all the work we've been doing with Martin Hirsch in theatre or has been in his free time, if he has any, which is not a transition plan, we need a more robust arrangement. And internal funding more. So we have a colorectal transition clinic. However, between directorates, no one can decide who will pay for the time for the adult surgeon to come to the clinic, which is not ideal. So that transition should be a priority for the trust and there should be specialist commissioning and funding for transitions so that we don't let our patients down discussing which directorate will pay for what work. And lastly, psychology. I'm sure as a colorectal surgeon, I should not be having discussions about the intimacies of sexual function in teenage girls. We need a dedicated service to think about how the problems of childhood will be transitioned into adulthood in a careful, mindful, holistic way. Thank you. I welcome your questions.
Thank you for waiting. Okay. So I'm Junaid. I'm one of the relatively new pediatric urologists that I joined here last year. And obviously, I was really excited to be part of this incredible institution and working with the big names like Prof. Kokila and stuff. But before I talk about ped urology, I wanted to just go through a little bit of history of Oxford, which I found really interesting. I don't know how many of you know about this. So this hospital was started by a group of people way back in 1758. And at that time, the funding of the hospital was around £4,000. And I calculated it was probably £4 million from current. There were surgeons in those times as well, but they had to pay a fee to be working in that hospital, which I find very interesting. Interestingly, the junior doctors were paid. So apparently there was a BMA there at the time. I don't know. So hospital was run by voluntary contributions. And if you had money, you would be paid the governor of the hospital, and then you get the esteemed right of getting patients admitted into the hospital, which was very interesting. That system ended a couple of years. Initially, we started with 2 wards, not surprisingly, and then they kept on increasing the number of wards. Not allowed for admission. These patients with smallpox, epilepsy, ulcers, cancers, TB, pregnant women, children under 7, no right for admission, or even mentally ill. Interestingly, patients who were admitted, they had to follow certain rules. So they had to behave with decorum. They had to attend chapel. They couldn't swear. They couldn't even play cards. If they wanted newspaper, it had to be approved from the local chaplain. Patients were expected to help the nurses, including cleaning and laundry. Maybe these things we should reintroduce. I don't know. Nursing, there were no trained nurses. There was one woman in charge, which I think was, one matron was in charge till probably 15 years ago, I think. If there was a lunch break, patients were left on their own. They had to look after themselves. And night hospital, there was only one nurse. And then gradually things moved on. We started outpatients in 1835. 10 years later, we decided, okay, medical and surgical patients should be kept separate. We were already part of University of Oxford. And then by 1939, there was a complete clinical school based at the John Radcliffe Infirmary. The first designated children's ward came roughly 80 years later in 1877, followed by maternity care, and then orthopedic center in 1918, which is currently the NOC. In 1919, there was some suggestion that we need to have a separate site for people with tuberculosis. So this John Radcliffe site was a sanatorium initially in 1919. Churchill Hospital was, at that time, was run by the Americans, interestingly, until the Second World War. And they left us, and then we got Churchill Hospital back. Finances were real poor at the time, so we had to sell part of the land. So the current JR site is about half the size of the original land which was bought. And then we kept on increasing the size and hospital. So this GR site started, the planning permission was granted in 1963. 1968 we started working, and it's still, 79 the first acute hospital was opened. So it sort of took its current shape in 1979. Some of the pioneering facts about our hospital: 1941, the first dose of penicillin was given in this hospital. And apparently the first accident service in the UK was started in 1941 here in Oxford. This Radcliffe Infirmary was closed in 2007, and currently it's taken over by the University of Oxford. My hospital, Children's Hospital, came into existence in 2007. It was part of the West Wing of the John Radcliffe. And now different departments, specialities of the pediatrics, they are consolidated under one roof. We deal with a lot of counties, as you can see. So going down from Southampton all the way up to Northampton, Cheltenham, and London. So the catchment is roughly in the range of 3 million for ped surgery and ped urology. It's a massive catchment for us. Current team, we have myself, Ashok, and Vajit, who sat here, and we have 2 lovely urology nurses. Services we provide, so we try and cover all aspects of ped urology, complex reconstructive, laparoscopic surgery. We have a lot of multi-MDTs, including spina bif, which I'm really proud of. So every month we have spina bif clinics, complex bladder clinics, antenatal counseling for antenatal ped urology issues. We have dedicated urogyne clinics, MTT. This is a huge achievement for us. And then we run DST clinics as well. We also have interventional radiology, which in adult world is probably quite a norm, but in pediatric world it's real best to have a very good interventional radiology team. We provide a lot of outreach service, ped urology service. We're part of research, a lot of studies, audits, projects are going on in my department. And it is an amazing center for visiting surgeons for ped urology and peri-surgical training. So we get a lot of fellows and observers from all across the world to come and work with us. As I said, we have an amazing urology nursing setup. There are 2 nurses, but they probably work for 4 nurses. They run 5 clinics a week. You can't imagine how many wetting bladders we have, so we deal with lots and lots, and the numbers are increasing every day. They supervise, they actually run the spina bif clinics, complex bladder clinics. And today, in fact, they're actually providing a training service for the community nurses, a community nursing team all across the region. So they're just a brilliant part of the ped urology service. Like other departments, ped urology has its own challenges. I mean, this is a massive draw, one of the biggest trusts in the country, but obviously with tight budgets, which is impacting us as a team as well. The patient load is going up every day, so I just calculated some things in 21. So we used to see probably 900 patients per year, but now it has gone up. It sounds not a massive increase, but if you look at the overall numbers, the numbers has gone up probably 3 or 4 times in the last few years only. But the facilities have not gone up, so we are struggling with the clinic wait time at the moment. It's way above 6 months easily, and the theatre waiting time, we're trying our best. I think the theatre waiting time has come down to less than 6 months now, because we're trying to do extra lists, trying not to miss any of our theatre list. So we're working really well as a team, with all 3 of us. Theatre's availability, we, as much as you know, all surgeons like to operate more. We would like to have more theatre capacity, but we are struggling. So that's why we are trying to address this by going to the outreach centers and start operating other centers. Staffing issue, junior doctors, we need more and more registrars, obviously. Equipment has been a problem because we use a lot of endoscopes, cystoscopes and stuff. We need new and new equipment. We do outreach pediatric services, Horton Hospital, and unfortunately they don't have pediatric scopes, so we have to carry our scopes from JR to Horton Hospital. So we're trying to get equipment to our district and other hospital sites as well. Oxford is a tertiary care center for pediatric referral, and we get lots of challenging and rare cases that we deal literally every day. And the numbers are going up. Service expansion and collaboration. So we're trying to expand. It has been a challenge in this financial financial constraints. So currently we are doing pediatric at Wrexham, Chipping Norton, and Horton Hospital. But the talks have already started in Reading. So we're trying to provide pediatric services. So we're hopefully in the next few months we'll be starting with pediatric clinics in Reading and hopefully theatres shortly afterwards. Milton Keynes, Stoke, and High Wycombe. There's some of the possible centres we'll hopefully try and work on. As my previous speakers were talking about transition, so we're also struggling. We had some success, so we have some named adult urology colleagues who are happy to accept the transitional patients. So we have a named adult urologist in Reading, we have a named adult urologist in Stoke Mandeville, but we need, if any of the adult urology colleagues in Oxford are listening, so we would really appreciate if they can contact me, and so we can set up a transitional service here in Oxford as well. So these just a quick summary of what we plan to do as a team in the near future. So in my previous hospital, I was the stone lead for the pediatric stone service. So I'm working on developing a pediatric stone service here. We have a very good interventional radiology team, which is quite an important part of any stone service. So we have we have a reasonable amount of equipment as well. I've already spoken with the adult urology team who deals with stones, and they're very supportive and they're very happy to help us set up the service. As I said, the urology nurses, they deal with a lot of day and nighttime bladder accidents, so biofeedback service. So we're fortunate enough, we've spoken to Oxford Charity. They very kindly have given us a grant to set up this service for the biofeedback. This will be a huge bonus for us. We are in planning to set up more specialist clinic to help our kids, nephrology, MDDs, reflux clinics, complex bowel and bladder clinics. As I said, we are expanding pediatric services to other centers, trying to get more and more equipment, not only for JR, but other outreach services. I was trained as a robotic surgeon in my previous hospital, and those of us who have seen and worked on robot, it is very sort of painful to come down to a laparoscopy. So I'm hoping at some point in the next few years, hopefully, when the financial situation is better. So I'm still working on it. I'm talking to different robotic companies and see if we can acquire a robot for our service. That would be a huge step forward. Already mentioned transition, so that's what we really want to do. Opportunities for improvements, I think some of the suggestions. So we are already working on it, but we would welcome if you want to be part of our research projects, if our training and research, if you want to spend time with us. We are working towards our referral criteria for patients. So because we have a massive clinic waiting list, we're trying to reduce the waiting list by establishing a referral criteria. So just to give an example, so I don't want to see a 2-year-old with a type 4 skin. So we get so many referrals for type 4 skin. So we're trying to develop a service, an information leaflet, training sessions for GP, primary care physicians, as well as the pediatricians in different hospitals. So we can reduce these referrals. We also be trying, so we have some named physicians. So as I said, we do spina bifida clinics once every month. So we're trying to have designated community pediatricians. So these kids can be managed locally, local hospital, and they only come to us if they need us, actually. And they can do regular scans locally without coming to us and increasing the wait time for radiology scans as well. I've always wanted to work as a team, so we work really well as JR, 3 of us, but we are building more and more PhD Urology. We're building up the PhD Urology network. I've recently joined international MTT with Birmingham, Switzerland, Cardiff, so we do these joint meetings once every month and discuss complex cases. We are working on guidelines and protocols. Antenatal protocol, we almost finalized, is in the process. We're trying to come up with perioperative and postoperative plans. And this is not just for JR, this is, we plan to do this, introduce this to the DGH as well, so that, whatever service we provide, whatever care we provide at JR, that should be translated exactly into the different hospitals. And we have, as I said, we have joint clinics with Urogyne, and we also operate jointly with the adult gynecologists, and that is a huge bonus for us because they have massive experience with complex gynecological, and they come and do joint procedures with us. So this is what I want to develop with the adult urologists, especially for the transitional patients. So set up a transitional clinic first, ideally with the adult urology team, and then do joint procedures with the adult surgeons as well, especially the bladder reconstruction work. We are part of a lot of workshops, and one of the meetings is SEEPS meetings, Southeast Asian Pediatric Surgeon meetings, but we're willing to be part of the adult urology joint workshops as well. And PhD Urology department is open to offer for observerships and rotation. So at the moment, there is a rotation of adult urology training that comes for 3 to 6 months and spend time with us, because PhD Urology is an important part of their curriculum for their FRCS exams as well. And then I believe there is a general surgical training coming as well for 6 months in the next near future. As I said, it will be very useful if we can have, we're already working together, so I'm inviting some senior PhD urologists to come and help me with complex bladder procedures as well. And I said earlier, we welcome any suggestions to do a joint audits, research projects, especially for, so when we transition our kids to the adults, we have absolutely no idea what happens to them. So it would be a really good insight for us if we do joint collaborative work with the adult teams. So this is my contact. I welcome any questions, suggestions, or if you want to be part of the team, long or short term. Thank you so much.